Thank you so much for that wonderful introduction, and thank you for allowing me to have the opportunity to share about my clinical research. I'd like to start by talking a little bit about a patient that I encountered early on during my postdoc fellowship that I'm on right now at Johns Hopkins University. We'll call this patient Billy. And Billy is a 12-year-old boy with a diagnosis of Tourette syndrome. Billy experienced a number of frequent and interfering motor and vocal tics that caused significant interference for him. But in addition to having a hard time with managing both his motor and vocal tics, Billy also struggled with a number of co-occurring challenges. In addition to the tics, he often experienced premonitory urge sensations, which are these uncomfortable physiological sensations that precede the occurrence of tics and play an important role in the cycle of tic expression. In addition to having a hard time with managing those urges and tics, Billy also had a difficult time with regulating his emotions. Oftentimes, he would frequently be overwhelmed with feelings of frustration and anxiety, and these emotions would exacerbate the expression of his tics. Upon presenting at the Center for OCD, Anxiety, and Related Disorders for Children, where I'm on postdoc, I was able to deliver an evidence-based intervention targeting his tics, the Comprehensive Behavioral Intervention for Tics, or CBIT. And through this protocol, I was able to work with Billy to work on building his awareness for tics and associated antecedents like those premonitory urges. And I was also able to coach Billy to learn competing response behaviors to inhibit his tics. And although Billy was engaged in treatment, he was still struggling to implement some of those behavioral strategies to work on his tics because of those co-occurring challenges that I mentioned. And it was through interactions with patients like Billy that's really inspired me to pursue clinical research, looking at evidence-based interventions, understanding their underlying mechanisms, and thinking about how can we improve patient outcomes for evidence-based interventions. And evidence-based interventions are really remarkable. We have a variety of different treatment protocols that have been shown by science to be effective to target a number of different neuropsychiatric conditions of interest for me, working with youth with tic disorders, anxiety disorders, and OCD. But here's the thing about evidence-based interventions. Although we know that these protocols are effective for a variety of different clinical populations, not all patients respond to evidence-based intervention. In fact, some patients might also have limited symptom improvement, not as much as we would like to see. Thinking about those behavioral interventions for youth with tic disorders, for instance, a seminal clinical trial showed that approximately 47% of youth with tic disorders did not respond to CBIT. And this theme of non-response to evidence-based interventions is not unique to tic disorders. We also see this across different clinical populations. Looking at literature for pediatric OCD, we can see non-response rates around 30%. And looking at randomized control trials for cognitive behavior therapy targeting anxiety disorders, we can see non-response rates around 40 to 50%. So taken together, this information has inspired me to pursue the research question, how can we improve patient outcomes for evidence-based interventions? And evidence-based interventions are great. We know that they're effective treatments that work for a variety of clinical populations, but they're kind of like a black box. We're not really sure what's going on inside the box to make these treatments so effective. So clinical researchers like myself are often found scratching our heads thinking, what's inside the box? What's driving these treatments and helping to see the symptom change that we're looking for? And in order to address this core question that I have, how can we improve patient outcomes for evidence-based interventions? It's often been said like that clinical psychologists wear many different hats. So to address this question, I found myself having to put on my mechanic's hat and be like, okay, in order to really dig into this question, we need to look inside the box, understand what are the gears that drive this machine of evidence-based intervention? What are the gears that make it work? So in order to address my core question of how can we improve patient outcomes for evidence-based interventions, I really see there's two different tracks we can take. First track is thinking about identifying those core mechanisms that drive evidence-based treatments. These are basically the big gears that make the machine work. If we can identify those core underlying mechanisms, then we can supercharge those gears and make sure that patients are getting the doses of things that they need in order to have positive outcomes. An alternative pathway, and one that's a little bit more creative, is thinking about what are some of the other underlying processes that run in tandem with these core mechanisms of evidence-based interventions. Essentially, what are these more smaller, seemingly overlooked gears that might play a role in enhancing or interfering with the core mechanisms of evidence-based intervention? If we can identify these small gears, then down the road, we can potentially target them by incorporating additional treatment elements into our existing evidence-based interventions. And in that way, we can bolster patient outcomes. So for the past few years, I've been wearing my mechanics hat, and I've been really honing in on identifying those small gears in order to improve patient outcomes. And one of my first research projects that I got involved in on postdoc at Johns Hopkins was looking at affect lability in youth with tic disorders. And affect lability is essentially difficulties with emotion regulation. And there are a number of reasons why affect lability is important to think about for youth with tic disorders. First and foremost, we know that emotions can play an important role in the cycle of tic expression. We also know that youth with tic disorders often struggle with comorbidity, psychiatric conditions like anxiety disorders and mood disorders. And there's also this notion that difficulties with emotion regulation might interfere with patients' ability to implement behavior therapy skills effectively. So think about it. If you're having a hard time managing your emotions, that might get in the way of your ability to implement core skills like competing responses to inhibit tic expression. So in this particular study, which I have linked with the QR code if you're interested in following up, we found that after controlling for tic severity, higher levels of affect lability predicted greater levels of tic-related functional impairment and non-tic-related functional impairment as reported by parents in a sample of youth with tic disorders. And this line of research got me thinking about the current state of the evidence for behavioral interventions for youth with tic disorders. So we have this great protocol, CBIT, but not everybody responds. And the interesting thing about CBIT is it doesn't necessarily address some of these smaller gears like emotion dysregulation. That's not one of the core components of the CBIT protocol. So what if we were to identify and target these smaller gears like emotion dysregulation by incorporating additional therapeutic skills into the current evidence-based treatment module? Could this potentially be an avenue to improve patient outcomes? And continuing in this line of work, thinking about another potentially important small gear that might be gumming up the works, so to speak, with behavioral interventions for youth with tics, is this novel concept of urge intolerance. Essentially, urge intolerance is this idea that individuals with tic disorders might have great difficulty tolerating those aversive, uncomfortable premonitory urge sensations that precede tics. And here, the idea is we might want to hone in on this because difficulties with urge intolerance could impede patients' abilities to effectively implement behavioral therapy strategies to inhibit tic expression. And what we found with this particular research project using structural equation modeling was that greater levels of urge intolerance were predictive of functional impairment due to tics as reported by parents and children in a sample of youth with tic disorders. So I've been wearing my mechanics hat and thinking about some of these smaller gears that are important. What can we actually do with this information? I find myself at this really exciting transitional point in my research career where I've been the mechanic for the past few years, identifying some of those important smaller gears. And now I'm pivoting more towards becoming an engineer and thinking about, now that we have some of these potentially important small gears identified, like urge intolerance, how can I think about small, meaningful ways to innovate current evidence-based practices in order to improve patient outcomes. And thinking about this line of research inquiry that I've going with youth with tic disorders, how can we take an existing evidence-based intervention like CBIT and target that smaller gear that's important, namely urge intolerance, by incorporating additional therapeutic elements into the program, like distress tolerance skills training? By targeting that smaller gear, can we potentially improve patient outcomes? And I'm really excited to be moving toward collecting pilot data, and it's my hope in the near future to submit a K award looking at distress tolerance as a way to target premonitory urge among individuals with tic disorders. And in the next 5-10 years, I plan to play the role both the mechanic, identifying those small stuck gears, and also being the engineer, thinking about how can we innovate existing evidence-based interventions in order to improve patient care across a number of different clinical populations. And I think what's really neat is this construct of distress tolerance might be a small but important gear across a number of different clinical populations, including tic disorders, anxiety disorders, and OCD. Because at the end of the day, I'm interested in thinking about how can we innovate existing evidence-based care in order to improve patient outcomes. And I'm happy to share, in case of Billy, about halfway through a course of CBIT, I was able to flexibly incorporate some mindfulness-based strategies into stress tolerance skills training. And those strategies, in conjunction with the CBIT protocol, helped him better manage those co-occurring concerns and tackle his tics. So I'm very excited moving forward to test out these concepts on in a larger, well-controlled study to see if we can help more patients like Billy. And I just want to take a moment to express my gratitude to all of my mentors, past and current, and say thank you to JCCAP and Division 53 for this wonderful award. And of course, thank you to the patients and their families who inspire us to do this meaningful clinical work. Thank you.